which are commonly asked in all the university exams. You can use the code Dr. Divya 20 for the first free live class. We have different subscription plans here. We have basic, standard, and mentorship. Mentorship is a wholesome program which we offer you at a special rate of 50,000. So here, in addition to pre-recorded classes, live doubt clarification, as well as quick revision examination module, we also offer you one-to-one personalized guidance as well as notes. So you can use the code Dr. Divya 20 for discount on the subscription too. You can as well book a slot for personalized counseling session where all the details will be explained to you. About the internal exam marathon classes, which we have started since April 22nd. It is for a duration of about 45 days. So here we are doing rapid revision of all important questions, quick revision of volatile facts, as well as we are covering the multiple choice questions. So this is beneficial for all the university exams of all the states. So with this kind of preparation, I'm sure you can get good grades in your exam. So you can use the code Dr. Divya 20 for the first free live class. So coming to the Upper Limb Marathon Series 2. So today we will go through these questions, very important. All of them are quite important questions. So we will be dealing with each of these questions separately. So first, about the essay questions, long and short essay. So first question is shoulder joint. So whenever any joint is asked, you have to follow the standard set of headings like under which you need to explain. So the type, the articular surfaces, the ligaments which provide support to the joint, and in certain joints like in shoulder, we also need to know about its relations, then the movements and the muscles producing the movements and applied aspects. So shoulder joint, it's a ball and socket type of synovial joint. So here the articular surfaces are the glenoid cavity of the scapula and the head of the humerus. Okay, so this forms the socket and this forms the ball. So here the ligaments, coming to the ligaments of the joint, first is the capsule, the capsular ligament. So the capsule, it extends here, that is from the supraglenoid tubercle to the infraglenoid tubercle. It encloses both the things. And here around the neck of the, the surgical neck of the humerus. In the lower part, it will extend up to the surgical neck of the humerus here. So the capsule is lined on the inner side by the synovial membrane. So this is the synovial membrane. The synovial membrane, it extends beyond the joint cavity, that is as the covering for the tendon of the long head of biceps. So tendon of the long head of biceps, it begins from this supraglenoid tubercle. And that tendon will be running through the joint cavity. So it will be covering this tendon. It forms the synovial membrane. It forms a synovial sheath covering the tendon of long head of biceps. Then it also has an extension here beneath the subscapularis, where it forms the subscapularis bursa. And posteriorly also we see it beneath the supraspinatus, where it will form a bursa. Other ligaments include the coracohumeral ligament, that is from the coracoid process of the scapula to the humerus. So coracohumeral ligament. Then we have the transverse humeral ligament, okay, which is that is between the greater tubercle and the lesser tubercle. It will be connecting here. So here we have the transverse humeral ligament. And then we have the glenohumeral ligament. So glenohumeral ligament is three types. It's arranged in three bands, like, superior, middle, and inferior glenohumeral ligament. So here if you see, so these ligaments which are within the capsule of the joint, here there is a gap between the superior and the middle glenohumeral ligament. A slight gap is there. So this is the reason why this is a little weak point, since there is a small gap between that, and that becomes the common reason for the anterior dislocation of the shoulder joint. And other accessory ligaments include the coracoacromial ligament, which has the posterior and an anterior band. Okay, coracoacromial ligament. This also forms the accessory ligaments, as well as the coracoclavicular ligament. So all these ligaments, they form the accessory ligaments of the shoulder joint. Next, coming to the bursa in relation to shoulder joint. So beneath the acromial process, we have the largest bursa in the body, that is the subacromial bursa. This is the subcapsular bursa. And here we have the synovial sheath around the tendon. So these are all basically the extensions of the synovial membrane itself. So here you can see the synovial membrane extends as the covering for the tendon of long head of biceps, that is synovial sheath. Here this is the capsular bursa, okay, and this is the infraspinatus bursa, that is beneath the infraspinatus muscle it lies. So okay, so these are the extensions of the synovial membrane into the neighboring structures. Coming to the relations here, okay, so now this is a sagittal section. Okay, it's not a transverse section, it is a sagittal section. So this is the glenoid cavity. Okay, so this will be superior, this will be inferior, this is posterior, this is anterior. Okay, so this is the subcapsular bursa. That is this is the synovial. This green thing is the capsule of the joint, and this is the synovial membrane, and this is the tendon of the long head of biceps, which we see within the synovial membrane here, right? So coming to the anterior relations here, we have this muscle is the subscapularis, because beneath that is the subscapular bursa is there. Okay, this is the coracoid process, and attached to the coracoid process will be the coracobrachialis as well as the short head of biceps, which have the origin from there. Here we will have see the anterior fibers of the deltoid muscle. This is the pectoralis major. Okay, so in that we will see the axillary artery and the axillary vein. Superiorly here, this is the acromial process. So subacromial bursa is there, and beneath that is the supraspinatus muscle. And behind posteriorly, we have the deltoid muscle. This is the infraspinatus bursa, infraspinatus muscle, and teres major muscle. Okay. And here inferiorly, we have the long head of triceps. Teres, sorry, this was teres minor. This is long head of triceps and teres major muscle. This is axillary nerve and the posterior circumflex humeral vessels. So these are the relations of the shoulder joint. It is very important. Relations of the shoulder joint can be individually asked as a 5-mark question. Arterial supply. So arterial supply is mainly by the posterior circumflex humeral artery, posterior and anterior circumflex. Where do we have here? Humeral artery, then the subcapsular artery, basically the branches of the axillary artery, okay? And the suprascapular artery. Suprascapular artery is a branch from the subclavian. Okay, so these are the arteries which supply the joint. The nerve supply, here the axillary nerve supplies the lower and anterior part, whereas the suprascapular nerve will supply the upper and posterior part, and lateral pectoral nerve will supply the upper and anterior part. Okay. So lower part and anterior, it is axillary, upper and anterior, lateral pectoral, and posterior it is suprascapular. So stability of the joint. The stability of the joint is provided by the muscles around the joint. That is the rotator cuff muscles which are present. So rotator cuff muscles are supraspinatus, infraspinatus, teres minor, and the subscapularis. So all of them, they form the rotator cuff muscles which will provide support. So the muscles are present all around. Okay, and see this way, they are present. Supraspinatus, infraspinatus, teres minor, and the subscapularis, which are attached to the greater as well as to the lesser tubercle around the joint. So they will give the stability to the joint. The other thing is the ligaments there. Okay, that is coracoacromial ligament. Okay, so this also provides the support there. Then the glenoidal labrum, okay, because the glenoid cavity is smaller compared to the head of the humerus, there is around that we have the glenoidal labrum is present, okay, the cartilaginous covering around that. So that also provides the stability to the joint. So movements of the joint here. So the shoulder joint allows for flexion, extension, abduction, adduction, medial and lateral rotation, as well as circumduction. So all the movements, they take place at different axes around the shoulder joint. Okay, so abduction and adduction, when we see here, the abduction is mainly 90 degree. 90 degrees brought about by the deltoid. Okay, then adduction is brought about by the pectoralis major here. The flexion and extension. Okay, so the flexion by the anterior fibers of the deltoid. Okay, and the extension is also brought about by the posterior fibers and the teres muscles. Okay, so they bring about the extension. Medial and lateral rotation. So medial rotation is by the subscapularis. Okay, subscapularis brings about medial rotation, whereas lateral rotation is by the infraspinatus as well as the posterior fibers of the deltoid. So they bring about the lateral rotation. So here above overhead abduction, okay, so up to 90 degree is brought about by the what is that? The deltoid muscle. Okay, so beyond that, what happens is the head of the humerus slips little below, and it is brought about by the trapezius here. Okay, so it brings about, that is beyond 90 degree, that is 120, 180 degree abduction. It is brought about by the trapezius there. Okay, so common conditions which we see is, one is in, especially in children. Okay, so here what happens is in children, since it is still not ossified, the bone is not ossified, near the growing end of the bone, it has a very rich supply of blood vessels. So sometimes if there is a bacterial infection, it can cause septic arthritis. Okay, then the dislocation. So dislocation, earlier it was said that inferior dislocation, but now we say because of that gap between the superior and middle glenohumeral ligament, we have anterior dislocation is more common. Posterior is the least common because the joint is very stable posteriorly. Okay. So these are the different anterior and dislocations posterior. Okay. Painful arc syndrome. So painful arc syndrome, what happens? Beyond 60 degree and up to 120 degree abduction, when we abduct, there will be pain. Okay. That is basically because here the subacromial bursa or the supraspinatus muscle, which is present here, the inflammation of that can cause the painful arc syndrome. Okay. So here you can see what happens is at up to that 60 degree, beyond that there is pain. Okay, when he is, but beyond that what happens is that is when we go beyond 120 degree, the head of the humerus little slips from the acromial process. Okay, it goes little behind for that overhead abduction. So beyond that degree, what happens? There is no pain because it slips there. So this impingement doesn't occur. Okay, impingement of this bursa doesn't occur, inflamed bursa, and so there is no pain. So he is wincing with pain here, and here he has abducted it above. So there is no pain in that region. So this is known as dwarf burn sign. Okay, dwarf burn sign. Other thing is the frozen shoulder. So basically it is because of the fibrosis of the capsule. Okay, so normal capsule will look fibrous. Fibrosis of the capsule can lead to restricted movements, and that is why it is known as the frozen shoulder. So if there is fracture is less common, okay, but if there is fracture, it is usually fixed by what we call it as arthrodesis, the process of fixing. Okay, so we basically pass the screws and the plates and it is fixed, the joint. Okay, so when we write about the shoulder joint, so the things which you need to must know are, you have to write about the type of okay, so shoulder joint, when we mention okay, so you write about the type of joint, then the articular surfaces. So what are forming the articular surface? So that is very important. Then you'll mention all the ligaments which provide support to the joint. You talk about the relations. Okay. And then we need to write about blood supply, nerve supply. You can write. Okay. And nerve supply too. Then applied anatomy. Okay, applied anatomy. So here, these things, okay, from the type to relations, they are very important. This has to, you need to know it, okay, and as well as the applied anatomy. So applied anatomy, it is asked like, like uh, clinical anatomy question, like where the condition is mentioned and anatomical basis for it is asked. So this is summary of shoulder joint. So next going to spaces in the hand. Okay, so spaces in the hand, when we say we have, you need to know which are those spaces where they are present. Okay. So basically the spaces of the hand, we have like palmar spaces. So palmar spaces here, when we say we have the mid palmar space, the thenar space, and the pulp space of the digit. So here will be considering the palmar space and thenar space I'll be telling you about. Okay. And there is the pulp space of the digit also. So those are the spaces in the hand. So those are in the palmar spaces when we say. Okay. Dorsal spaces, they are in the dorsum of the hand, the dorsal subcutaneous space. Okay. And space of Parona. That is in the dorsal part, there is also here below in the hand region, okay, where the forearm and that is almost close to the wrist joint, we have also space of Parona. But now we'll be talking about these spaces, that is the mid palmar space and the thenar space. So mid palm, so when we talk about these spaces, you have to talk about the boundaries of that, okay? So where they're located. So it is located under the medial half of the hollow of the palm, okay? So medial half of the hollow of the palm, we have this mid-palmar space. Okay, so anteriorly from superficial to deep. Okay, anteriorly from, this is the space. So anteriorly from superficial to deep, what do we have? We have, now this is the skin. So beneath that is the palmar aponeurosis. Okay, palmar aponeurosis. This is the superficial palmar arch. Okay, superficial palmar arch. Then digital nerve and vessels. Okay, beneath that will be the digital, that is the nerve supplying the digits, supplying the 3.5 digits, okay, fingers. Then there is this ulnar bursa, which will be enclosing the flexor tendons of the medial 3 fingers. These are the flexor tendons. Flexor tendons in the sense, both the flexor tendons, that is flexor digitorum superficialis and flexor digitorum profundus. Okay, so both of them, including we see, which are enclosed within the ulnar bursa. Then we also see the medial 3 lumbricals. Okay, so lumbricals will be in relation to this tendons, right? Lumbricals have the origin from these tendons, that is flexor digitorum profundus. From there it has the origin. So medial 3, that is the second, third, and fourth lumbricals are seen. When we see posteriorly here, it is the fascia covering, the fascia which covers the interossei. Okay, and medial 3 carpals. These are the 3 carpal bones. So the interossei muscle as well as the carpal bones are there. Then laterally, it is the intermediate palmar septum. This is the intermediate palmar septum, which is present laterally, which extends from the medial edge of the palmar aponeurosis to the third metacarpal bone. Okay, so this space separates this mid-palmar space from the, that is the septum. It separates the mid-palmar space from the thenar space. Then medially, there is the medial palmar septum extending from the medial edge. Okay, so this was extending from the lateral edge. This is extending from the medial edge. Okay, so from the medial edge of the palmar aponeurosis to the 5th metacarpal, up to 5th metacarpal it extends. So this is the medial palmar septum. And here the hypothenar muscles. Okay, beyond that there will be the hypothenar muscles. So it separates this medial palmar septum, separates the that is the burst, that is the mid palmar space from the hypothenar muscles. Okay, so distally, what happens is this mid palmar space, it becomes continuous with the medial 3 web spaces, okay, through the 3 lumbricals, okay. So what is the clinical importance here of the mid palmar spaces? The ulnar bursa, okay, so and the ulnar bursa is considered as the inlet for infection. and lumbrical canals as the okay, so basically what happens is through the ulnar bursa, the infection, it is occurs. Okay, infection can get in through the ulnar bursa. And the infection, the outlet for the infection will become that is the lumbrical canals through this mid-palmar space. Okay, so the pus from this space is drained by basically making incisions in the web spaces. Then we have the thenar space. So this is the thenar space. So thenar space, if you see, it is roughly triangular. Okay, it is a space located under the outer half of the hollow of the palm. Okay, so here the boundaries, if you see from superficial to deep, we have the palmar aponeurosis. Then beneath that will be the digital vessels and nerves supplying the lateral 1.5 digits. Then the radial bursa. Okay, radial bursa, which will be enclosing the tendon of flexor pollicis. So this is the flexor pollicis, tendon of flexor pollicis longus. Okay, and these two are the tendons, flexor tendons to the index finger. Okay, flexor tendons to the index means both flexor digitorum superficialis and flexor digitorum profundus tendon. Then we have the first lumbricals. Okay, so lumbrical will be here in relation to this flexor digitorum profundus tendon. So first lumbrical. So these are the anterior relations. Laterally, it is the lateral palmar septum extending from the lateral edge of the palmar aponeurosis to the first metacarpal. Medially, it is the intermediate palmar septum. Posteriorly, it is the fascia covering the transverse head of adductor pollicis. This is the transverse head of adductor pollicis, and this is the fascia covering that. Okay. And proximally, what happens is the fascia is limited by the fusion of the anterior and posterior walls in the carpal tunnel. Okay. Distally, it becomes continuous with the lumbrical canal. Okay, lumbrical canal. So here the infection may reach, any infection can reach this thenar space from the infected radial bursa. So radial bursa is this side, from the radial bursa or from the synovial sheath of the index finger, it can reach here. So the pus from the thenar space is drained by an incision in the first web space. Okay. So that is about the spaces. Okay. So when we talk about the facial spaces, basically, so when we talk about the facial spaces, okay, facial spaces or spaces in the hand, facial spaces in the hand, we talk about palmar spaces, which include mid-palmar, okay, mid-palmar space. Then we have the thenar space and the pulp space, okay, and the pulp space. So this is one, facial spaces, you have to classify. Then second thing is the dorsal spaces. Dorsal spaces include the subcutaneous, dorsal subcutaneous, okay, dorsal subcutaneous space and dorsal subaponeurotic space. Okay, subaponeurotic space. Then third will be the space of Verona. So these you talk about in facial spaces. So I have dealt with the palmar spaces, that is mid-palmar and thenar space mainly. So there we talk about its boundaries and the clinical aspects. Okay. Next is the arches, palmar arches. Okay, so palmar arches are mainly formed by the arteries. So where is located the two types of it, formation and its branches. Okay, so arteries in the hand, what happen is they form, okay, the terminal parts. So mainly the arteries there are the terminal parts of the ulnar artery and the radial artery. Okay, so when they enter the palm, they will form an arch, which we call it as the superficial and the deep palmar arch. So superficial palmar arch, when we come to, okay, so this is the superficial palmar arch, and here beneath that will be the deep palmar arch. Okay, deep palmar arch is here. So superficial palmar arch is the direct continuation of the ulnar artery. So if you see here, it is mainly formed by the ulnar artery. Okay, and contributed a little by the radial artery. Okay, so what happens is, this is the flexor retinaculum. After the ulnar artery crosses, okay, the flexor retinaculum, it extends beyond that and forms a loop here, okay. So it forms an arch. So it enters the palm and the artery curves laterally behind the palmar aponeurosis, okay, and in front of the long flexor tendons. And this concavity is directed towards this. This is the concavity. It is directed this side towards the wrist joint, whereas the convexity is towards the digits. So the arch here, it is completed laterally by anastomosing with one of the branches from the radial. So here, when we see here, okay, so this is the lighter color. This is the superficial palmar arch. Okay, so here on this side, it is completed by one is the superficial branch of okay, so here if you see, this is the superficial branch, palmar branch of radial artery, or by the contribution from Princeps pollicis artery, or by the radialis indicis artery. Okay, so this is the radialis indicis artery. So contribution by these, either from superficial palmar branch of radial, okay, or Princeps pollicis artery, or radialis indicis artery. So these three arteries, they contribute to the completion of this superficial palmar arch. Next is the branches. So if you see here the branches, it forms three common, okay, 1, 2, 3, three common palmar digital arteries. Okay, so these palmar digital arteries, they go to the interdigital cleft between the fingers, and each of them divides into two proper digital arteries. Okay, so they will be supplying the adjacent sides of the arteries. So that is, so three common digital arteries it gives, which will divide into proper digital arteries. Then it gives one proper digital arteries, which runs along the medial side, okay, of the little finger. Then it also supplies, gives cutaneous branches to the palm, okay. So here the relations of this is superficially, because it just lies beneath the palmar aponeurosis, okay. So superficially we have the palmar aponeurosis. Deep, there are long flexor tendons of flexor digitorum superficialis and flexor digitorum profundus. Then there is lumbricals and digital branches of the median and ulnar nerves that will form its relations, deep relations. Next, the deep palmar arch. So this is the deep palmar arch. So deep palmar arch is the direct continuation of the radial artery. So the arch is completed on the medial side, okay, by anastomosing with the deep palmar branch of ulnar artery. Okay, so that is how it is completed. So here the radial artery will enter the palm from the dorsal aspect of the hand here by passing between the two heads of the dorsal interosseous muscle. So after it enters, it gives off two branches, okay, immediately. That is the Princeps pollicis and the radialis indicis artery, okay. Then it will anastomose with the deep palmar branch of ulnar artery, forming the deep palmar arch. So here the branches include three palmar metacarpal arteries, okay, three palmar metacarpal arteries. So this will join the palmar digital, common palmar. So these are the palmar metacarpal arteries. And three perforating arteries that pass through the second, third, and fourth interosseous space to anastomose with the dorsal metacarpal arteries. Then there is also a recurrent branch which runs in front of the carpals to end in the palmar carpal arch. Okay, so near the carpal bones. So here relations. So the deep relations are the proximal parts of the shaft of the metacarpals and the interosseous muscles. Superficially, so it is between the flexor tendons and the interosseous, okay, deep palmar. Whereas superficial palmar is between the palmar aponeurosis and the flexor tendons. So here the superficial will be the flexor tendons and the lumbricals. So basically here if you see, it lies about 1 centimeter proximal to the superficial palmar arch. So applied aspect here basically is what happens is any laceration of this palmar arterial arches, okay, lacerated wounds can cause bleeding, profuse and uncontrollable bleeding. So here usually what they do is to avoid the loss of blood, you compress the brachial artery. Okay, brachial artery is compressed against the medial side of the that is in the mid-arm. Okay, so that is the most effective way to control. Otherwise, in this palm, it is very difficult to control the bleeding. Okay, so okay, so here basically why we do the brachial artery is, even though if we ligate the ulnar or the radial artery here, it is not able to control because of the connections of these arches with the palmar and dorsal carpal arches. Okay, palmar and dorsal carpal arches, which are formed near the wrist joint. This will also make a connection. So because of that, we are not able to control. So best thing is the feeding artery main, that is the brachial artery, we will compress. Okay, so when we write about the arches, okay, so the palmar arches, we have to the superficial and the deep. Okay, so superficial, where it is located, you need to write location, deep location, then the formation. So here mainly it is the ulnar artery. Here mainly it is the radial artery. Okay. So with what are the contributing arteries from the radial you should write. Then you write about its branches. And then you write about the relations and applied aspects. So next we move on to the intrinsic muscles of the hand. Okay, intrinsic muscles of the hand. When we say intrinsic muscles of the hand, that means the muscles have the origin and insertion within the hand itself. Okay, so that is why they are called as the intrinsic muscles of the hand. Okay, so first we will classify them, intrinsic muscles. Okay, so we have the thenar muscles. Okay, the thenar muscles, the hypothenar muscles. So we have the thenar muscles, the hypothenar muscles. Thenar muscles are to the thumb. Hypothenar muscles are to the little finger. Okay, then we have the lumbricals and the interossei. Lumbricals and the interossei muscle. Okay, so that is palmar and dorsal interossei muscle. So the thenar muscles, okay, which are attached or which are the muscles of the thumb. So we have three, that is the abductor pollicis brevis, opponens pollicis, and flexor pollicis brevis. Okay, abductor pollicis brevis, it has the origin from the tubercle of the scaphoid and the crest of the trapezium. Okay, as well as from the flexor retinaculum, it has the origin and it gets inserted abductor, no? So it has to get inserted on the lateral side of the base of the proximal phalanx of the thumb. So it brings about abduction. Flexor pollicis brevis. So flexor pollicis brevis here, it has two heads, okay? The superficial head is from the distal border. So you can see this is the flexor retinaculum here. So distal border of the flexor retinaculum. Deep head comes from the trapezoid and the capitate bone. It is also getting inserted, okay? Flexor pollicis, lateral side of the base of the proximal phalanx of the proximal phalanx of the thumb. Then opponens pollicis here. Okay, opponens pollicis is from the flexor retinaculum as well as the crest of the trapezium. So it gets inserted to the lateral border, okay, of the first metacarpal bone, okay, lateral border of the first metacarpal bone. So basically it brings about opposition of the thumb with the other fingers. Then we have the hypothenar muscles. There are three: abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. So abductor digiti minimi, it has the origin from the pisiform bone as well as from the tendon of the flexor carpi ulnaris. So it gets inserted to the ulnar side. Okay, it gets inserted here to the ulnar side. Means basically ulnar side, when we say, it is the medial side, okay, of the base of the proximal phalanx of the little finger. So it brings about abduction of the little finger. Then flexor digiti minimi brevis. Okay, so flexor digiti minimi here, it has the origin from the flexor retinaculum as well as from the hook of the hamate, and it gets inserted on the ulnar side of the base of the proximal phalanx of the little finger. Okay, so along with the abductor. So it brings about the flexion. Then we have the opponents here. It is from the flexor retinaculum and hook of the hamate. So it gets inserted to the medial surface of the shaft of the fifth metacarpal bone. Okay, so it brings about opposition of the little finger with the other fingers. So the lumbricals. Okay, so the lumbricals, we have the origin of the lumbricals. So how many lumbricals we have? We have 4 lumbricals. Okay, so here you should know the first and second lumbricals are unipennate, whereas the third and fourth are bipennate. So the first and second lumbricals, they come from the lateral side of the tendons of flexor digitorum profundus. The third and fourth, they come from the adjacent sides, okay, of the medial 3 tendons. That is the second, third, and fourth tendons. Okay, so here it comes. So basically these lumbricals, okay, lumbricals. So nerve supply, lumbricals, where are they getting inserted here? If you see here, the tendons, they get inserted into the lateral side of the dorsal digital expansion of the corresponding. So there is a dorsal digital expansion between the digits, okay? So it gets inserted into that. So corresponding to the digit, that is from the second to the fifth. So the nerve supply here for the first and second lumbricals is by the median nerve, and the third and fourth lumbricals is by the deep branch of ulnar nerve. Okay, ulnar nerve. Right. Then coming to the actions. So lumbricals, since they are present here, right, they bring about the flexion of the metacarpophalangeal joints. Okay, it brings about the flexion of the metacarpophalangeal joints, and it extends the distal interphalangeal, okay, distal and proximal interphalangeal joints. Then we have the interossei muscle. So interossei muscles, we have palmar interossei and dorsal interossei muscles. So palmar interossei muscles, there are 4 small muscles. Okay, they are located between the palmar surfaces of the metacarpals. So from lateral to medial, we call them 1, 2, 3, 4. Okay, palmar interossei. So dorsal interossei, they are located between the shafts of the. So here you can see palmar and the dorsal interossei. Okay, dorsal interossei, there are 4 small muscles which are located between the shafts of the metacarpals here. So if you see here, the palmar interossei, the first and second, they get inserted. Okay, first will be here. Your first is not shown. So they get inserted onto the. See, palmar interossei, the main action of palmar interossei, remember for the actions, pad and dab, okay? Pad for palmar interossei, dab for dorsal interossei, okay? So palmar interossei, they bring about adduction. So if they have to bring about adduction, what happens is they are inserted into the. So these 2 fingers, they have to bring closer, isn't it? So they get the first and second, they get inserted onto the medial side of the base of the proximal phalanx, okay, of the first and second here. That is the thumb and the first digit. Whereas this side too, that is the third and fourth palmar interossei, they get inserted onto the lateral side of the base of the proximal phalanx. Dorsal interossei here, they are bringing about abduction. So they have to move the fingers away from the center. Okay, so center is, we take it as the middle finger. So from there it has to move. So where it has to get inserted here. So if it has to move, okay, so it gets inserted here, the dorsal interossei. Okay, so the first dorsal interossei, it gets inserted, okay, onto the lateral side. Okay, the second and third, they get inserted on either side, that is lateral and medial side of the middle finger, whereas the fourth, it gets inserted onto the medial side of the base of the proximal phalanx. So that is its insertion. So all the palmar and dorsal interossei, they're all supplied by the deep branch of the ulnar nerve. Okay. The thenar muscles, they are supplied by the median nerve, whereas the hypothenar again by the ulnar nerve, deep branch of the ulnar nerve. Okay, so you can see it here. So this is the dorsal interosseous muscle. Okay, so that is about this muscles. Okay, so you need to, what do you need to write? Intrinsic muscles. What do we mean by intrinsic? Okay, that the muscles have origin and insertion within the palm itself. So you classify them as thenar. Then we have hypothenar. Okay, then we have the palmar and dorsal interosseous, palmar and dorsal interosseous muscle. And we have the lumbricals. Okay, so you talk about their origin insertion, you give the origin, you give the insertion of all the muscles. Then the nerve supply. Nerve supply is all by the deep branch of ulnar nerve, except for the thenar muscles which are supplied by the median nerve. Okay, and you have to talk about their actions. Okay, so thenar muscles accordingly they bring about the flexion, the abduction, as well as the opposition movements. Whereas the lumbricals, they bring about the flexion of the metacarpophalangeal joints and extension of distal and proximal interphalangeal joints. Palmar interosseous palmar brings about adduction, dorsal brings about abduction. Okay, then we move on to rotator cuff muscles. Okay, so rotator cuff, when we say, okay, so what do we mean by rotator cuff? So basically the four scapulohumeral means the muscles which are having the origin from the scapula getting inserted around the humerus. Okay, so they are known as the scapulohumeral muscles. Okay, they are called as the rotator cuff muscles because they form the musculotendinous rotator cuff around the glenoid, that is the shoulder joint. Okay, so this, since it is muscles and the insertion is by its tendon, it is also called as the musculotendinous cuff. Okay, so we can see here, this side from the front anteriorly we'll have the subscapularis. This is the supraspinatus, infraspinatus, teres major. Okay, SITS. So this is called as the sits muscle, SITS, that is the supraspinatus, infraspinatus, okay, teres minor and subscapularis altogether. So what is the importance is these cuff muscles, okay, they play a very important role in stabilizing the shoulder joint. So the primary function of that is basically to grasp, to get hold of the shoulder joint, the large head. It holds the entire head like that, okay, of the shoulder joint. That is the humerus, head of the humerus it holds and holds it against the smaller shallow glenoid because the glenoid cavity is small. Okay, so it will hold the entire muscles between that. So usually these rotator cuff muscles, they are prone to, especially in that fast bowlers and all, it is more common for tear. Okay, it's more prone for tear, especially the supraspinatus tendon. Okay, it's a common tear which we see. Then this above the supraspinatus, there is this bursa. Okay, so the bursa can get impinged and it may cause impingement syndrome. Okay, rotator cuff muscle tear. Another thing is because of the overuse. Okay, improper use, overuse of the rotator cuff muscles, especially during the rotatory movements of the and the shoulder near the shoulder joint, it can also lead to overuse tendinitis. That is the inflammation of the tendinous insertion. So that is the thing which you need to write for rotator cuff muscles. Okay, so what do we mean by rotator cuffs? So, and so they are the six muscles. Okay, so you talk about their origin insertion. When it is a 5-mark question, you need to talk about its origin insertion also. If it is a 3-mark question, you just have to mention which are those 6 muscles. Okay, and their function. What is its function? It basically holds the head of the humerus. It basically provides the stability to the joint by holding the head of the humerus against the glenoid. So that you will write and its applied aspects. Okay, rotator muscle tear, then okay, rotator muscle tear as well as tendinitis and impingement syndrome. Next is clavipectoral fascia. So clavipectoral fascia here, Okay, we talk, so it is a fascia, isn't it? Clavipectoral. So where it is present, the location, so it is present in the pectoral region beneath the clavicle, and it extends up to the axilla. Okay, so what is this attachment? What are the structures piercing it, and what are the structures enclosed by it? Okay, so attachment. So attachment, when we see of this is the clavipectoral fascia. So it is attached. Now this is the clavicle. This is the inferior surface of the clavicle, where we have the subclavian groove. Okay, so in that subclavian groove, there is the subclavius muscle. Okay, so we have the subclavius muscle here. So the fascia is attached to the anterior and the posterior lips of the subclavian groove. Then it fuses, forms a single, and again splits to enclose the pectoralis minor muscle. Then both the lamina again they fuse together and it forms a suspensory ligament. It gets attached to the base of the axilla where it maintains the dome shape of the axilla. Okay. So you can see here. So it basically encloses two muscles, that is the subclavius and the pectoralis minor muscle. Okay, so so what are the structures piercing it? Okay, so structures piercing it, you can remember the mnemonic clap. Okay, clap. C is for cephalic vein. L is for, L is for lymphatics here. A is for acromiothoracic artery or thoracoacromial artery, is otherwise called as acromiothoracic artery. Okay, and the P is for pectoral nerve. Okay, P is for the pectoral nerve. So cephalic vein, the lymphatics, the acromiothoracic artery, and the pectoral nerve. So they are the structures which will pierce the clavipectoral fascia. Okay. So those are the things which you need to write for clavipectoral fascia. So its location, where it is, its attachment, above and below. Where is the attachment? And then you talk about the structures piercing it, as well as structures enclosed by it. Okay, that is enclosed by it is two muscles, pectoralis minor as well as subclavius. Next is axillary group of lymph nodes. Okay, so this is a very important question, axillary. So you have to talk about location, what are the areas it drains, and its clinical importance. Okay, so axillary group of lymph nodes, as the name says, they are present in the axilla. Okay, so it comprises of 5 groups here. We have the anterior, posterior, lateral, central, and apical. Okay, so 4 groups. So basically, they are located along the tributaries of the axillary vein. Okay, along the tributaries of the axillary vein. So you can see this is the axillary vein, right? So these are the branches of the, that is the tributaries of the axillary vein. Okay, so that is the long thoracic vein, and this is the subcapsular vein. So along that we have it. Okay, so when we write the answer, we can write it making 3 columns. So anterior or the pectoral group. So it lies along the lateral thoracic vein. Okay, lateral thoracic vein at the lower border of the pectoralis minor. So here you can see. Okay, and at the pectoralis, sorry, major. It lies at the lower border of the pectoralis minor, not major. Here, this is a mistake. Okay, it's pectoralis minor. Then it drains. Basically, it drains the upper half of the trunk. Okay, upper half of the trunk as well as the major part of the mammary gland. Then the posterior group. Okay, posterior here. We have, it lies on the posterior axillary fold along the subcapsular vein. So it drains the upper half of the trunk posteriorly as well as the axillary tail of the breast. Then the lateral group of lymph nodes, they lie along the upper part of the humerus. Okay, that is in relation to the axillary vein. So they mainly drain the upper limb. Central group, they lie in the upper part of the axilla and it receives basically the lymph from all these. That is the anterior, and posterior lateral. Okay, it receives central group. So that's why it's central. Then apical or infraclavicular, it lies deep to the clavipectoral fascia at the apex of the axilla along the axillary vein. So it will receive lymph directly from the upper part of the breast as well as indirectly from from this central group of lymph nodes. Okay. So these lymph nodes, they are classified according to the levels. Clinically, the classification is as level 1, level 2, level 3. Okay. So level 1, what do we say is below the okay, so below the lower border, okay? So this is below the lower border of the pectoralis minor. The level 2 lies behind and the level 3 is above. Okay, so below and lateral. So below and lateral to the pectoralis minor is the first group. Behind is the second group and above and medial is the third group. So level 1 includes the, which one? The pectoral group as well as the lateral group. Whereas the level 2, which is behind, includes the central group. Okay, central group, and above and medial, it includes the this one, apical, supraclavicular. Those will be the above. So this is clinically. So when they do a radical mastectomy, okay, in breast malignancy, where they have to remove the lymph nodes, accordingly, they remove level 1 lymph nodes, level 2 lymph nodes remove means this is what we mean. Okay, so this is how we palpate. So palpation of the axillary lymph nodes is an important part of examination, especially while examining the mammary gland for any swelling. And okay, sometimes the axillary, the follicles in the axillary region can get infected and then they can form an axis. These are the furuncles or the boils which we see it in the axillary region. Okay, so basically the inflammation of the hair follicles are seen. Okay, so you should know in axillary lymph nodes. Okay. So what are the things you're going to write? So their location, where they are. So you can make a column and write location. Then you talk about their area of drainage. Okay, area of drainage you talk about. Then you talk about their clinical classification. Okay, clinical classification has 3 levels, 1, 2, and 3. And the applied aspects you can mention. Right. Then we go to scapular anastomosis. So scapular anastomosis, the location, the formation, and clinical importance. Okay. So when we talk about scapular anastomosis, it is basically the anastomosis between the branches of axillary and the subclavian artery. Branches of subclavian and axillary artery, they form an anastomosis around the scapula. So why this is important is basically it forms a collateral circulation when any of the branches are blocked. Okay. So either the subclavian or the axillary, if it is blocked, this forms the collateral circulation. So the anastomosis takes place at 2 sites, around the body of the scapula and near the acromial process. Now, around the body of the scapula, it is by the circumflex scapular artery, which is a branch of subscapular artery from the third part of axillary artery. Okay. And the suprascapular artery, which is a branch from the thyrocervical trunk, that is from the first part of the subclavian, as well as from the deep branch of the transverse cervical. Okay, deep branch of the transverse cervical. So they form an anastomosis around the body, and that is one. Next is around the acromial process. So acromial process, the acromial branch of posterior circumflex humeral artery, the acromial branch of thoracoacromial artery, and the acromial branch of suprascapular artery. They form an anastomosis around the acromial process. So that is called as the acromial anastomosis. So these are the 2 anastomosis which takes place around the scapula. Okay. So you will mention scapular anastomosis when we talk about anastomosis. It takes place at 2 sites, the body and the acromial process. Okay. So basically it is between the branches of subclavian and that is the first part of subclavian and second or third part of axillary artery. axillary artery. Okay. So you will mention which are the contributing arteries there and write about the next is intermuscular spaces. They are also known as scapular intramuscular spaces. So here basically the muscles which are originating from the scapula getting inserted to the here on the humerus. Okay. So during its course of origin and insertion, they enclose certain spaces, and that is known as the intermuscular spaces. Okay. So here when we see, so this is the easier way. So if you take the left hand, this is the right hand. Okay. So these horizontally running will be the teres minor muscle and teres major muscle. Okay. Here it will be the shaft of the humerus. This is the humerus and this is the triceps brachii muscle. Okay. Triceps, long head of the triceps. So teres, so horizontal fingers will be teres minor and teres major. So this is for the spaces you have to show it on the right side. We show it this way. So this is the triangle, upper triangular. This is the quadrangular space. This is the lower triangular space. Okay. So this hand you can consider it as the scapula. So teres minor, teres major. So these are the spaces. So when we talk about here, like this is the teres minor, this is the teres major, long head, and the long head of the triceps, and this is the shaft of the humerus. So this is the upper triangular space. So upper triangular space, the content is the circumflex scapular artery. So upper triangular space is bounded above by the lower border of the teres minor and upper border of the teres major, and base is formed by the long head of triceps. Okay, base is formed by the long head of triceps. So content is the circumflex scapular artery. Then we have the quadrangular space. So here the upper border is formed by the lower border of teres minor, lower border is formed by the upper border of teres major. Then laterally it is the surgical neck of the humerus. Medially it is the lateral border of long head of triceps. Okay. So this is, so what is the contents? Whatever structures are around the surgical neck, that is the axillary nerve and the posterior circumflex humeral vessels. Okay. So that will be there. Then the lower triangular space. Lower triangular space, here the base is formed by the lower border of teres major, laterally by the shaft of the humerus, medially by the long head of triceps. Okay. So this space here, we will see the radial groove. So what structures pass through the radial groove? That is the radial nerve and the profunda femoris, profunda brachii artery. Profunda brachii artery. So these are the structures passing there. So these are the contents. This is what you need to write for that. Okay. So location, boundaries, contents, and applied aspects. We're coming to the deltoid muscle. So deltoid muscle here, if you see the origin, insertion, nerve supply, action, structures under its cover, and the clinical importance. Okay. So deltoid muscle has a wide origin. Okay. So it originates from the lateral 1/3 of the clavicle. Okay. So lateral 1/3 of the clavicle. Then the lateral margin of the lateral 1/3 means the anterior border of the lateral 1/3 of the clavicle. Then the lateral margin of the acromion, the crest of the spine of the scapula. Okay, so here it has its origin and it gets inserted into the deltoid tuberosity of the humerus. Okay, so this muscle now, it is a like these fibers and the posterior fibers, they are unipennate here, whereas these are multipennate. Okay, these are bipennate, these are the multipennate fibers here. The middle fibers, they are multipennate fibers. Understand? So all of them, they get inserted to the deltoid tuberosity. So what is the action of the muscle? Deltoid muscle, why it is important? It is the main chief abductor of the shoulder joint. Okay, it brings about abduction of the shoulder joint and it is supplied by the axillary nerve. So what are the structures? So if you remove the deltoid muscle, what are the structures we will see? One, the joint. The joint, which joint do we see? The shoulder joint is seen. Okay, shoulder joint we see. Then whatever muscles are there, the muscles which we see will be the subscapularis, that is all the rotator cuff muscles, supraspinatus, infraspinatus, teres minor muscle. Okay, they are enclosed there. And we also have the long head of the triceps present there. Okay, and then The nerves and vessels will be the axillary nerve and the posterior circumflex humeral vessels, as well as anterior circumflex humeral vessel is there. And also you have to talk about the bursa which are present there, okay? Around that is the subacromial bursa. Then we have the subscapularis bursa there, okay? So those are the structures beneath the cover of the deltoid. So deltoid muscle is other importance is it forms the site for injection. Okay, so how do we give the site? So we take the midpoint, that is from the acromial process to the deltoid tuberosity. Okay, we see the midpoint, we give the injection, because below that there are nerves, axillary nerve and all is there, so we give. Otherwise, we make 2 finger breadth, 2 to 3 finger breadth from the acromial process down. It is the injection site here. Okay. So this is the action of the deltoid muscle. So the anterior fibers, they also help in the flexion, extension of the shoulder joint. Posterior fibers will help in the extension. The middle fibers, they bring about the abduction. Okay, so under these headings, you need to origin, insertion, nerve supply, action, structure under discover, and applied aspects. Next, coming to the short answers, palmar aponeurosis. Okay, so palmar aponeurosis, what do you mean by palmar aponeurosis? Its location and attachment functions. Okay, so palmar aponeurosis, when we see, it is the what is palmar aponeurosis? It is the modification of the deep fascia. Okay, palmar aponeurosis, it forms the modification of the deep fascia of the palm. Okay, so it is also considered as the degenerated part of the palmaris longus muscle. Okay, so this the deep fascia here, what happens is in the palm, it is thin over the thenar. This is the thenar, this is the apothenar part. It is thin over this part, whereas in the center it gets thickened. Okay, it modifies, it forms the palmar aponeurosis. So the palmar aponeurosis, it is very well defined area here if you see. Okay, so basically it covers the long flexor tendons as well as the superficial palmar arch. It basically protects that superficial palmar arch and underlying nerves. Okay, so here its apex here is directed. Okay, if you see the apex is directed proximally here. Okay, so the apex is directed this side proximally towards the wrist, and its base is directed distally towards the root of the fingers. So here the palmar aponeurosis will have an apex, it has a base, it has a medial border, and it has a lateral border. So the apex here, it is narrower, okay, so and blends with the flexor retinaculum. So its fibers, they are continuous with the palmaris longus tendon. So that is why it is considered as the degenerated part of it. The base here, it is broad, okay, and the distal, and just proximal to the heads of these, okay, the proximal to the heads of the metacarpals, the base is divided into 4 longitudinal slips, okay, one for each medial 4 digits. Medial 4 digits, for each digit, there is one slip, okay. So each slip will again further divide, if you see here, it will divide into 2 slips that blends with the fibrous flexor sheath of the corresponding digit. So this is the fibrous flexor sheath. So along with that sheath, it gets blended. So the digital nerves and vessels will and the tendons of the lumbricals emerge through this interval. Okay, so between this, if you can see here, there are the digital nerves and vessels you can see. Even the lumbricals can be seen there. Okay, then the medial border. So the medial border, that is the aponeurosis, is continuous with the deep fascia covering the hypothenar muscles, and it also gives origin to the palmaris brevis muscle here. This is the palmaris brevis. The lateral border here of the aponeurosis is continuous with the deep fascia covering the thenar muscles, okay? And the lateral palmar septum extends inward. From this edge only, the lateral palmar septum will extend, separating the thenar muscles from the mid-palmar space, isn't it? So functions. So basically, it helps to improve the grip of the hand by fixing the skin, and it protects the underlying tendons, nerves, and vessels. Okay. So the condition, dependence contracture. Okay, applied aspect is you should write about dependence contracture. So it is basically a progressive fibrosis in the medial part of the palmar aponeurosis. Okay, so that is called as the dependence contracture. So that is what you will write for palmar aponeurosis. Then carpal tunnel syndrome. So carpal tunnel, okay, carpal tunnel. So it is a osteofibrous canal, okay, because below there is bones formed by the bones, and above there is the flexor retinaculum. So between the retinaculum, that is retinaculum is basically the deep fascia, right? Now it's again a modification of the deep fascia. So this is the fibrous part, this is the osteo. So it is a osteofibrous canal, which is seen beneath the flexor retinaculum, carpal tunnel, okay. So you should know what is the what do we mean by carpal tunnel syndrome. So here within the carpal tunnel passes all the long flexor tendons of the forearm, isn't it, to get inserted into the hand. So along with that will be the median nerve. Okay, so median nerve will be passing beneath that. So sometimes what happens, this nerve gets impinged or compressed in this tunnel, okay, that is in the carpal tunnel. So there is compression of the median nerve. So because of the compression, okay, so there is sensory as well as motor symptoms along the nerve supply of the median nerve, along the force supply. So what happens is, here there is pain. So the median nerve, the skin, okay, so there is tingling and sensations and the pain over this aspect. So basically it supplies the lateral 3.5 fingers here. Okay, so the thumb, here you can see some tingling sensations and pain, as well as there will be wasting of the thenar muscles. Okay, wasting, which we saw it in this previous picture. So there is wasting of the muscles because the nerve is supplying the thenar muscles is the median nerve. Okay, so that is the carpal tunnel syndrome. So basically you have to talk about the clinical, why there is wasting in carpal tunnel syndrome. That is, you should know the clinical anatomy or anatomical basis for that. Okay, so that way. Then we have the radial and the ulnar bursa. Okay, radial and ulnar bursa. So, okay, so what do we mean by that? So we have two bursa, radial and the ulnar. So you can see this is the radial bursa, this is the ulnar bursa. So ulnar bursa now here if you see the long flexor tendons of the fingers, okay, that is the flexor digitorum profundus and flexor digitorum superficialis tendons. Okay, so when they pass through this osteofibrous carpal tunnel, they are enclosed by a common synovial sheath. So this common synovial sheath, we call it as the ulnar bursa. So the tendons, they invaginate through this sheath from the lateral side. Okay, so the ulnar bursa, it will extend proximally into the forearm. Okay, so you can see here proximally it will extend a little bit into the forearm. Okay, you can see these tendons passing through that, right? So, so it extends, okay, so about 5 centimeters proximal to the flexor retinaculum. Distally, it will extend in the palm up to the middle of the shafts of the metacarpals, okay, metacarpal bones. So the distal end of this ulnar bursa is continuous with the digital synovial sheath. Only here, okay, the medial end, if you see, only with this one, little finger, it becomes continuous. It's continuous with the digital synovial sheath of the little finger, okay, here. So that is why any infection here can spread, but any infection in these synovial sheath, it gets restricted only in the finger spaces, okay, it doesn't get extra because this is not continuous, but in the little finger region, it can get continuous with the within the ulnar bursa, and then from there to the space of Parona, it can get extended. The radial bursa, when we see, the tendon of the flexor pollicis longus, while passing through the osteofibrous canal, it also gets enclosed within the synovial sheath, and that is called as the radial bursa. So proximally, it will extend into the forearm for about a finger's breadth. Okay, and that is beyond the flexor retinaculum, and distally it is continuous with the digital synovial sheath of the thumb. Okay. So basically they are separate, both ulnar bursa and the radial bursa, they're separate from each other, but beyond the flexor retinaculum, that is proximally they can communicate. Okay, so this is basically the infection here. Okay, the little fluid here from the ulnar bursa. There is collection of the pus. Next, we move on to the anatomical snuff box. Okay, so what do we mean by that? And the boundaries, contents, and clinical importance. So here, the anatomical snuff box, when we see, okay, so what is this anatomical snuff box? See, this why it is called anatomical, that is snuff box, is basically because people, those who sniff the snuff, right, they keep the snuff in that hollow here, the space what is formed here, and they rub it and then they sniff it. Okay, that is earlier ages, olden ages, they used to do that. So that is why they used to powder that in that space and then they used to sniff it. So that is why it is called as the snuff box. Okay, so it is an elongated. So what is the definition of it is? It's an elongated triangular depression seen on the lateral side of the dorsum of the hand. Okay, so when we hyperextend the thumb, we will see that anatomical snuff box. So boundaries here, if you see, anterolaterally, that is tendon of the abductor, pollicis longus, and tendon of extensor, pollicis brevis. Abductor, pollicis longus, and tendon of extensor, pollicis brevis. Posteromedially, there is the tendon of extensor, pollicis longus. The floor of it is formed by the, okay, the floor is formed by the scaphoid as well as trapezium, and the roof is formed by the skin and the superficial fascia. Okay, scaphoid and trapezium here are the floor, and roof is formed by the skin and superficial fascia. Content is the radial artery. Radial artery is the content, and the structures which cross the roof deep to the skin is, one is the cephalic vein, and which turns from medial to the lateral side, and terminal branches of the, this is the terminal branch of the radial, superficial radial nerve, which crosses from lateral to medial side. Okay, cephalic vein, from medial to lateral it comes, whereas this one nerve crosses from the lateral to medial side. Okay, so what is the clinical significance is, we can feel the pulsations of radial artery in that space. Then the tenderness in the anatomical snuff box, it indicates fracture of the scaphoid bone. Okay, cephalic vein here, which is here, is the, usually we use the cephalic vein which is present there to give intravenous injections. Okay, and superficial branch of the radial nerve. Okay, it can be, because it is crossing here, it can be rolled over that tendon of extensor pollicis longus. Okay, so these are some of the important clinical aspects of anatomical snuff box. Okay. So thanks for watching Auricle. You can download the app on Google Play and App Store. And for more social contents, you can follow our social media handles, that is on YouTube, Instagram, Facebook, as well as Telegram. So until next time,